Hello friends, good afternoon. You must have enjoyed initial three lectures on fetal echo. Now moving forward with the next lecture. Now we are going to discuss some topics which are got little more complex and they are more interesting. I will be discussing more cases. I request you to observe this lecture in a dim light so you can see the sonography images better or 2D echo images better. So today's first topic is double outlet right ventricle. Double outlet right ventricle means both great arteries arises from right ventricle, which is far more common than double outlet left ventricle. Both semilunar valves, aortic and pulmonary valve, are committed to right ventricle. It is one of the most diverse pathology. There can be varieties of VSD, subaortic, subpulmonic, inlet, outlet, perimembranous, non-committed, and occasionally we can have a double outlet right ventricle with intact IVS, and left ventricle has no egress and it's very small. As I already mentioned, double outlet left ventricle is rather uncommon. There is some embryological reasoning to it. It may present with variety of combinations of semilunar valves and great arteries like pulmonary stenosis, atresia, aortic stenosis, atresia, coarctation, interruption of arch, AV valve atresia, common AV valve etc. Common AV valve DOR is seen with situs ambiguous. We will be discussing it when we discuss situs ambiguous. So these are the common pathological varieties seen. This is both great arteries from RV. This is subaortic VSD, subpulmonic VSD, doubly committed VSD, remote VSD, or inlet or mid muscular, whatever you mean to say. Functionally, there are four types of DORV. Most common is tetralogy of Fallot-like, where it is a VSD-PS physiology. Second is large VSD. It behaves like a VSD. There is no obstruction to pulmonary stenosis, so it increases pulmonary blood flow. Then something called as TGA type or Taussig Bing. It comes with subpulmonic VSD, dilated MPS, small aorta, and generally associated with aortic arch anomaly like coarctation. And last, not so common, is non-routable VSDs. All these VSDs or DORVs has got a unique ways of management. So when we diagnose these types of DORVs, we need to know what are we going to tell the parents. So in diagnosis of individual type is important. So we will be discussing these varieties when we deal in our presentation. So first case is a 21 weeker is a TOF like physiology or VSD-PS physiology. VSD can be routed to aorta with small pulmonary annulus. Gradient won't be seen, but pulmonary annulus will be small, aorta will be large. So this is the four chamber view. This is right ventricle, left ventricle, mitral, tricuspid, and VSD. This is the VSD. This is the spine and sternum. So this is the how orientation. So left axis. Another view. This is VSD, LV, RV. This is VSD. Just to make you aware of how the VSD looks like. VSD, we can see the VSD even when the inlets are opening, the AV valves are opening. It so there may be an inlet extension to this VSD. Now this is the aortic wall. This is left ventricle, right ventricle. This is aortic wall. If you draw imaginary line extending from VSD, aorta is committed to the RV. This is the mitral wall. I have just made a diagram here, and this is the imaginary plane of interventricular septum. So aorta is committed to right ventricle. There are a lot of discussion whether aortomitral continuity is must or not. or discontinuity for diagnosis of DRV. However, new thought says aortometal continuity or aortopulmonary continuity is not a necessity. You can have or may not have. So its definition is more to do with semilunar wall and ventricles, semilunar wall and right ventricle, not with the aortometal continuity. So this is the pulmonary artery. This is small. This is aorta. This is the big aorta. This is small pulmonary artery. There is a bifurcation C. This is the one branch. This is another branch from MPA. So when we put color, the things become a little more obvious. This is aortic arch. This is a sweep with color compare just to make understand how it is the anatomy looks like. This is LV. The VH is committed to the LV. It can be routed to LV. So it looks like arising from LV. However, the semilunar wall is mainly committed to LV. And we can see more or less crossing outlets. This is the VA aorta. This is the pulmonary artery. So there are the crossing outlets. So it's a top-like physiology. The crossing outlets are occasionally seen with DORV. Not all DORVs come with a parallel. We'll see some cases with DORV. Again, this is the aorta, this is MPA, this is MPA bifurcation. The branch, the RPA is just seen on color, not on 2D image. This is LPA. This is the DTA. Now DTA is on left side, so it's a left aortic arch. So this is a three vessel view. We can only appreciate aorta, not the MPA, and this is small right SPC. Coming to a second case is a 26-weeker child, 26 to 70, 16-weeker child, and with difficult imaging, we try to appreciate how it looks at 16 weeks. So this is aorta that is looks committed to right ventricle. So aortic arch. An important thing we note here is the flow reversal in duct. Under surface of aorta, there is a duct and there is a flow reversal in this. This is right ventricle, this is aorta. Try to understand the aorta is committed to right ventricle, and this is the mitral valve, and this is LV, left ventricle. So aorta is committed to right ventricle. So aorta from RV in another image. Just to make diagnosis of DOR, we have to demonstrate that way. Aorta is coming from right ventricle. This is spine, this is sternum here anterior, this is posterior, this is left ventricle, right ventricle. RV giving rise to aorta. This is a sweep. So the RV giving, this is aorta, this is small MPA. Aorta and small MPA here. MPA bifurcation is also seen. Aortic arch, small duct, flow reversal in duct. Again, aortic arch and small duct flow reversal and the one of the branch pulmonary artery. This is most likely RPA. Now, occasionally we can have a physiology that the pulmonary stenosis or atresia isn't developing. So there will be forward flow in pulmonary artery and flow reversal in duct if the pulmonary atresia isn't developing. This may be a case something like that. So this is a aorta and forward flow in MPA. Just try to appreciate the blue flow in MPA. Okay. And this is the small MPA arising from RV. So we have demonstrated both the great arteries arising from right ventricle. MPA from RV, the forward flow is present. If we follow up this patient, we have to continuously look for whether the forward flow remains patent or it goes, because there are high chances that the baby may develop pulmonary atresia on follow-up. Again, MPA arising from RV. This is left ventricle, right ventricle. Sagittal plane. This is image. Dominant left ventricle. Also appreciate echogenic focus in left ventricle. Sorry, right ventricle. This is dominant right ventricle. This is left ventricle. The mitral wall is more cranial. Tricuspid is more apical. LV, RV, and echogenic focus in RV. Just appreciate. Echogenic focus you can see anywhere. There's one in LV also. This is a sweep for us to understand the relationship. Just try to go through this sweep 3-4 times, 4-5 times. I'm going to run it for you for 4-5 times so you understand the segmental anatomy in better way. So left aortic arch, AV concordance is clear, and aorta is big, PAs are small. Aorta looks arising from RV, DORV like substrate. Also note fundic bubble and cardiac apex is on same side, most likely a satus solitous substrate. In all the cases, I do demonstration of left and right side and fundic bubble is on left side. So this is a satus solitous devocardia. Another image looks like a Malaline VSD, but it's committed more to the right ventricle. So more like a DORV substrate. Now another patient. This is 33 weeker. This is left ventricle, right ventricle. This is a mitral wall. This is aortic wall. Aortic wall is committed totally to the right ventricle. If this is the pen, we extend ahead towards aortic wall. Aorta is committed to right ventricle. Okay. Just look at this image again and again to appreciate why it's a DORV, not just plain VSD. Now this is aorta arising from right ventricle. This is left ventricle. This is MP arising from the right ventricle. This is the origin of MPA from our right ventricle. LV, RV. The fundic bubble seen just below the heart. Aortic arch. Now this 4 vessel view instead of 3 vessel view. Bilateral SVC, aortic arch, ductal arch, MPA. In this case, baby being little large, 33 weeker, we can see all anatomy quite clearly than the case initially where it was a 16 weeker baby. Demonstration of pulmonary veins, just to make a point, because unless we demonstrate pulmonary vein, there can be some surprises too. Because if this comes with the full anomalous connection, we are maybe dealing with status anomalies. Sweep. So we see a dilated CS initially, and then AV concordance, DORV, aorta, left arch. Just see this sweep 3-4 times, 4-5 times. Try to understand how segmental anatomy looks like in a sweep. It is more confusing because there is a left SVC that creates confusion and impression of a prime MSD. So whenever there is a left SVC, there is some confusion whether it is a prime MSD, but it's not prime MSD. It's a only yeah, there is no atrioventricular septal defect in this case. Again, 17 weeker, small baby. It looks like a non-committed VSD. We'll see how it's non-committed. It's far placed. LV, RV, AV walls, spine, anterior. Just to make orientation. Now, this is the LALV, left atrium, left ventricle. This is the VSD, and here is the aorta, RV. So I just made a diagram here. Mitral wall, LV, RV, and aorta. Aorta from RV, aorta from right ventricle. This is far from the left ventricle VSD. So long tunnel if you want to. make it. LA, LV, and the small thing that you come see here is MPA origin. Will demonstrate it further. So these are the great arteries, aorta and MPA posterior. This is anterior aorta, MPA posterior. Okay, I've just made a diagram here. RV, LV. This is right ventricle, left ventricle, aorta, MPA. More or less, like there is no crossing great arteries. Aortic arch, ductal arch. This is SVC. A bit of modified three vessel V, we can say. In three vessel, we only see aorta, small MPA is not seen, but there is no flow reversal in the duct. Sweep, just to demonstrate the segmental anatomy. This is MPA anteriorly, LV, RV, MPA, PA. Aorta anteriorly, PA posteriorly. Aorta anteriorly. This is big one is aorta, small is MPA. Chordocranial sweep. So DRV, VSDPS, one more case we will see just to make anatomy clear. It's four chamber view, LV, RV, AV valves, spine. Now this is a sagittal plane, little parasagittal plane, and we can appreciate aorta as anterior, MPA is posterior. So this is anterior aorta and posterior MPA. We'll demonstrate this in colors for you to appreciate. This is left ventricle, this is right ventricle. Now, typical that we see is a parallel great arteries. These are seen in this. These are the parallel great arteries. This is SVC, aorta, MPA. I'm not showing you still images. I'm showing you moving images. I'm used to that. There's a bifurcation of MPA, one vessel, another, and one goes here. So MPA bifurcation. This is aorta. Just to demonstrate drainage of pulmonary veins, this is the spine. These are the veins. This red one and this blue one. LVRV. Echogenic focus, again to just demonstrate it can be seen anywhere. Just don't miss it or just don't make a fuss of it, I would say. Sweep to demonstrate the great arteries are not crossing. They are parallel orientation of great arteries. You can appreciate the parallel orientation of great arteries here. Okay. These are the LV, RV, aorta, and both great arteries are arising from the RV, which is more big than the LV. Just see it again and again. Again, one more chordocranial sweep, the same patient, for us to understand anatomy better. LV, RV, both great arteries arising from RV. No crossing of outlets. No crossing of outlet is important feature, and parallel great arteries is an important feature to understand. One more sweep for just to understand both great arteries from RV, which is anterior. No crossing of great arteries. This is. I am showing you different images because all features may not be included in one case. They are seen in different cases. So I'm just presenting you different cases for you to understand the anatomy better. Fetal echo is all about understanding anatomy and segmental analysis. Once we understand anatomy and segmental analysis, we will improve our accuracy of diagnosis. This is lateral sweep, not conventionally done, but I have just done to demonstrate anterior-posterior relationship and how ventricle and great arteries are oriented with one another. Not easy to understand because we are not accustomed to it. I do it occasionally to see whenever I do echo, I just create an image of heart in my mind and then I take a sweep and I see what is coming at what plane. Now coming to important transposition of great arteries with intact IVs. With VSD, I'll discuss some other time. I'm just discussing the simple transposition. So important feature of transposition is LV is giving rise to pulmonary artery and RV is giving rise to aorta. Okay, so normally this is the place of aorta, but aorta is shifted here, and this place of MP is shifted here. Okay, this is left main, this is right coronary artery. So we will not see a crossing, we will see parallel great arteries. This is mitral wall, tricuspid wall. So aorta classically is right and anterior to PA. Sometimes in orientation is little change, or in fetus it is little weird. It is one of the common. Second common after tetralogy of Fallot. Even if we diagnose it at 35, 36 weeks, we can deliver baby in a pediatric cardiac setup. So baby doesn't collapse immediately after birth. If we diagnose after collapse of baby, then surgical mortality is high. So even if you diagnose at 35, 36, 38 weeks, it's okay. It's good that its diagnosis is made. That's important in TG, even in all cyanotic heart diseases. That even at late week, the station diagnosis is picked. It helps to deliver baby. It comes with variety of anomaly: VSD, left-sided obstruction, right-sided obstruction, pulmonary stenosis, aortic stenosis. All these seen in a high-volume setup. It can be seen with situs solitus, inversus, all possible. So important features of fetal echo are four-chamber view will be normal. Great arteries will be parallel. Aorta is from RV and aorta gives rise to neck vessel. MPA will be from LV. It bifurcates to either lung. As aorta is more superiorly placed in three vessel view, only two vessels are seen. Aorta and MPA or duct are not in same plane. CCTJ and PA can have similar anatomy. Now I am just demonstrating you a small sweep, LV giving rise to vessel that is bifurcating, and this is anterior aorta. Okay, the bifurcating vessel is PA arising from LV. This is spine left ventricle. We will study it in detail. This is MPA, this is aorta, this is SVC. Okay, so there's a little change in orientation of three vessel view, but we are not seeing all the vessel in one plane. Okay, this is the SVC, aorta, MPA. Parallel great arteries, aorta, MPA, SVC. There are no crossing. Okay, just understand the orientation of great arteries, how they look. My images, I do not take very classical images, but this is how it looks. Now, this will clearly demonstrate the VA dissociation and AV concordance. So, LA, LV, LV to PA, RA, RV, RV to aorta. Okay, this is very typical, and the outlets are not crossing, outlets are parallel. Very important feature of TGA. Once we understand this in a strip, we will not miss the diagnosis. Now coming to another, and this is a little tricky anatomy. Problem is that aorta is anterior to PA. This is small is aorta. This is just a 16 weeker baby. This is aorta. This is MPA. I have made a diagram. Aorta, MPA, and SVC. Okay, handwriting may not be very great. This is vertebra or spine. So aorta, MPA, branch PS, duct, and small SVC. Just get a orientation, because many times aorta, MPA are confused as a single vessel. Now that creates a confusion why there is only single vessel, why it is done TGA. Okay, again similar thing. This is the aorta, small thing. This is the MPA here and bifurcates here. So these are two vessels. This is not one vessel. These are two vessels. Aorta, MPA. Okay, same. Aorta, MPA. This is aorta, MPA. Yes, I'm showing you same thing in different planes to make aware how the anatomy looks in different planes. Same patient in different views. Now just look at the sweep, it will make diagnosis clear for you. In initial case, we saw parallel, but The 16-week are a little weird position. We may not see the parallel, but we see at least there is a crossing, non-crossing gate arteries, and we can appreciate bifurcation of MPA, and MPA is arising from left ventricle, and RV is giving rise to aorta. AV concordance, VA discordance. Okay, so it's a TJ at 16 weeks. Important is again not to confuse this as single vessel. There is no VSD. IVS is intact in this case. So again, appreciate the VA discordance and non-crossing great arteries. They are parallel great arteries. The vessel first term is MPA and then second term is aorta. And if we go in the third three vessel view, we can see only one vessel. That is the aortic arch. These are the parallel great arteries here. This is LV, MPA, RV, aorta. RV giving rise to aorta. This is the parallel. This is no crossing here. Same patient, prone position, spine, aorta from RV, LV giving rise to MPA. The two AV walls, two semilunar walls can be clearly seen here. This is the aortic wall, this is pulmonary wall. Okay. Generally, pulmonary wall is anterior, aortic wall is posterior. Now in TJs, the things are reverse. Aortic wall is anterior, pulmonary wall is posterior. And the other two arches. This is the MPA ductal arch, and this is the aortic arch. Now, MPA looks like this normally. Now in TJ, aortic arch look like this. This is more cranially placed, and this is the PA. So the position is also reversed. See this image again and again for you to understand how it looks. I'll just make a schematic presentation. RV, aorta, LV, MPA. Parallel origin of great arteries. This is another case. This is the LV and MPA, RV and aorta. Okay. Four chamber view is otherwise bang normal. Nobody will suspect any heart disease in this case. And then this is aortic arch, which otherwise in a normal heart will be ductal MPA. This is aortic arch, but this is not a MPA and ductal arch. And this is the MPA here. This is the MPA and this is the aorta. Again, parallel vessels. Demonstration of parallel vessels is important to diagnose TG. CCTJ also have parallel vessels, but it also comes with AV discordance, RA to LV and LA to RV. This is not the case with plain TJ. This is a plain TJ we are discussing, plain transposition of the arteries. I am taking a reverse sweep just to differentiate the ductal arch from MP, aortic arch. The anterior one going is aorta and posterior is the ductal arch. Just they separate from one another. Just see, this is the SPC. They are being in one line makes diagnosis a little confusing in TG. Aortic arch. Another case, aortic arch, ductal arch, parallel great arteries, very clearly seen in this case. This is right ventricle from the trabeculation, aorta. Again, what point I was saying, this is the MPA giving rise to RPLP and aorta here. You just need to understand that these are not a single vessel, these are the two vessels overlapping one another in the sagittal plane, the semi-sagittal plane. It will oblique from the sagittal plane. Once we understand this orientation, we will won't be missing TGs. So parallel great artery, this is the aortic arch, ductal arch. Coming to another important diagnosis, hypoplastic right hand syndrome. It is also called as pulmonary atresia intact interventricular septum. What is hypoplastic right heart? It's a spectrum. Spectrum of defect. There are many things. It comes in various sizes and shapes. Can be at one end we have got a very small RV, right ventricle. Generally, RV has got three components: inlet, cavity, outlet. Inlet trabecular portion, outlet. In this case, trabecular portion may be absent, or in trabecular portion outlet may be absent. So it can be mono or bipartite. And tragus will be narrow. At another extreme is RV is very dilated with severe tear and no forward flow occurs. Occasionally, severe form of Epstein anomaly, severe TR, they are not able to generate forward flow across pulmonary artery, and that leads to functional pulmonary attrition, not anatomical, functional. Okay, TR leads to no forward flow across. Occasionally, I have seen a case at a term diagnosis is difficult. Demonstration of PR may be important. That leads to circular circulation in this case. So this is a LA, LV, aorta, normal anatomy, and RA, small RV, small tricuspid wall, atresia pulmonary wall, small PA, and the flow reversal in duct. Important feature is flow reversal in duct. Okay, this is the important feature. No forward flow and flow reversal in duct. No forward flow in pulmonary wall, duct flow reversal in duct. So R will be non-apex forming or hugely dilated. Tricuspid volume is small or severely dilated, enlarged. No flow across pulmonary wall. That is important feature. Flow reversal in arterial duct or duct dependent pulmonary circulation. Cardiothoracic ratio will be normal or increase. Close differential is Epstein anomaly, but in Epstein we have to demonstrate apical displacement of tricuspid wall, which is not seen with the PIVs. It's a progressive disease. Important thing to remember. If you suspect a small RV in a case at say 16 weeks, 18 weeks, and follow up, if there is a flow acceleration at pulmonary wall, follow up, they may develop into pulmonary atresia intact IVs. Pulmonary atresia may not be seen. If not seen, show the color demonstration. Flow reversal in arterial duct I already mentioned. All these varieties have got different prognosis, from single ventricle to biventricular, and different management strategies, coronary dependent circulation. So understanding the spectrum of disease is very important. Now look at this four chamber. Most important thing we diagnose is LALV is good size, spine, normal left-sided apex. RA is small, okay, but important is RV is very small. You can just barely see the tricuspid wall with small RV that is not going up to the apex. Normally in fetus, RA and RV, LA and LV, LV and RV are of the same size. LV, RV are of same size. In this case, LV is big, RV is very small. So forward flow in aorta, LA, LV, aorta. This is the forward flow across aortic. And this is a flow reversal in duct. Aortic arch, duct. This is the red duct. Okay, flow reversal in duct is important thing to demonstrate. Just see this image again and again, how aortic arch and flow reversal in duct. Again, showing flow reversal in duct. In three vessel view, this is SVC, aorta, and that red dot seen here is a flow reversal. The sweep, just to appreciate single wave of other wave wall is very small. Okay, and one great vessel is seen. Other vessel can be demonstrated only on flow reversal. Flow reversal in duct. This is the forward flow in aorta, and flow reversal in duct. This is a PW, pulse wave Doppler. Another patient. RV is little big, but is non-apex forming. The apical portion highly trabeculated, small size. TV is difficult to appreciate. Tricuspid wall are here LV, LA, and metal are normal size. Spine, normal apex, normal cardiac axis. Same. This is a RV, LV. RV is small, not going up to apex. LV is apex forming. Now, in this case, pulmonary arteries are of good size. This is branches, aorta. We can appreciate the membranous pulmonary atresia, or sorry, valvar pulmonary atresia. Pulmonary wall annulus is very small, and there is no forward flow. I'll demonstrate that. And now, in this case, this red flow is a flow reversal in duct. Okay, this is the flow reversal in duct, no forward flow, and the forward flow we see is in the branch PS. Okay, this is RPA, LPA. The branch PS is a forward flow, and this is a C. Can we see the flow reversal in duct? This is the arch, and this is the duct, ductal arches. That is showing flow reversal, red flow. Okay, so flow reversal in duct. So this is spine, forward flow in aorta, and flow reversal in duct. Forward flow in aorta and flow reversal in duct. This is the flow reversal in duct. Sweet. Just to appreciate that RV is small. Okay, and ABBA concordance, aortic arch. Now this baby was 27 weaker, RV, right ventricle, small non-apex forming, trabeculated, small tricuspid wall, large LV, spine, normal apex, spine. This is the spine, this is normal apex. This is the pulmonary veins, just to orient oneself with the heart anatomy. Now the pulmonary wall, there is no movement, and there is a, this is the MP is smaller than aorta. This is unusual. MP generally bigger than aorta at 27, 28 feet. So it's MP is smaller than aorta. And this is the flow reversal. This is aortic arch and flow reversal in duct. Okay, no forward flow in MPA. Just see this image again and again. Okay. In this, the ducts are vertical. The anatomy is little different from the normal heart. So again, aortic arch, flow reversal in duct, MPA, main pulmonary artery. This is branch plates. Flow reversal. It's important that we demonstrate flow reversal. I am showing you again and again in different angles, different planes, that how flow reversal demonstration is important. Aortic arch, flow reversal. Blue flow, red flow. Red flow is for duct flow reversal. I just recently did this. This was referred to with a dilated single ventricle, maybe right, and very small left ventricle, and severe abival regurgitation. This is a 14-week repeat, 14 week, 4 days. It's a difficult imaging, but whatever I could see, I am sharing with you all. So the red flow is a severe abival regurgitation, and big right atrium, big right ventricle, small LALV. In fact, LALV is not small. LALV is normal size. RARV that is dilated. So it's other way around. Something is dilated, other is small. Not the RARV is normal and LALV is small. Understand the difference in wording. Where we can appreciate LA, LV, intact IVS, RV, RA. So all 4 chambers, spine, cardiac apex. Okay. And this is the aortic arch. Proximal aorta, aortic arch. We can't see, this is the SVC, and we can't see the other vessel. See, in these cases, when other vessel is not seen, we try to put a color Doppler, try to keep low Nyquist limit, but sometimes with low Nyquist limit, color get too much plain. But we cannot demonstrate other vessels. And the vessels at this age, 14 weeks, are very small. They may be just a millimeter or even less. Aortic arch, this baby was continuously moving. Again, 3 vessels we are not showing on the vessel, only 1 vessel, 2 vessels are seen. This is a short axis, this is dilated RA, RV, this is aorta. That's all. Now this case has shown a little bit of, this is the flow reversal in here. This is aortic arch and flow reversal in duct. This is again the flow reversal in the duct. The vertical duct, the flow reversal may be difficult to demonstrate. This is a sweep. I understand that it is difficult to appreciate what is happening, but just to demonstrate, we can see grossly one side is big, other is small. Sometimes it can be confused with a single ventricle. It's okay. Spend your time. This fetal echo sometimes may take 1.5 hours to complete because baby keeps on moving. It's a small baby. Orientation is not fixed. Sometimes it's prone, then it goes to supine and lateral views. So So I recently completed my half marathon just to promote long distance running as a recreational activity.